Welcome back, everyone, to another episode of the NRG Oncology Podcast. Today, Stephen and I are at the 2024 American Society for Clinical Oncology here in Chicago, where we're getting in on the action as it happens. It's been an exciting conference for NRG Oncology so far, with a lot of high-profile presentations from a number of our trials.
Last night, we heard results of the long-awaited NRG LU002 trial evaluating local consolidative therapy for oligometastatic non-small cell lung cancer. And we thought it'd be the perfect time to interview the principal investigator of LU002, Dr. Puneeth Iyengar, who is a professor of radiation oncology at the Memorial Sloan Kettering Cancer Center. Just for full disclosure, Dr. Iyengar trained me in thoracic radiation oncology when I was a resident and is a longtime mentor of mine, so I'm not the least bit biased here.
I like this throwback relationship. For those of you unfamiliar with Dr. Iyengar, he has been working in this area of oligometastatic disease for over a decade and has led numerous clinical trials to define the role of radiation and local consolidation in this area. Dr. Iyengar, I want to congratulate you on the presentation of NRG LU002 last night and welcome you to the podcast.
Well, it's a wonderful opportunity. I thank you both, Lauren and Stephen, for this visit, and I do have a special place in my heart for Stephen, as he was probably my most successful resident, and he's turned out to have a wonderful career. So I'm very happy to be here.
Well, glad to have you again. And to start off, for people listening who might not be familiar with all the nuances of oligometastatic disease, such as de novo oligometastatic disease versus oligoprogression versus an induced oligometastatic state, it's really, interesting. 15 years ago, you taught me about all these concepts, and I'd like you to just tell the audience a little bit more about these nuances and definitions.
So at the end of the day, historically, radiation was used in a palliative setting for advanced lung cancers. And since I study lung cancer, I'll speak to that specifically. And so our palliation was for bleeding, it's for obstructive symptoms, it would be for disease that was going to cause neurologic compromise. In the 1990s, doctors Wexelbaum and Hellman here at the University of Chicago, where we were sitting for ASCO, realized that there may be a state between a patient's early stage disease and when they develop widely metastatic disease. And they call that naturally oligometastatic disease. Historically, that meant that patients would have 3 or 5 or fewer lesions that were independent of their primary disease that were metastatic. And the idea would be, if that state existed and that state of oligometastatic disease lasted, then maybe there's a benefit of adding local therapy in combination with systemic therapy to not just palliate patients, but to improve their overall survival or their progression-free survival. And so there were several other key historical evolutions that took place that made that concept more relevant. One was improved imaging that allowed us to capture disease at earlier points in time, even in the metastatic state. 2, the development of improved systemic therapies that were able to control microscopic disease, leaving the only gross disease as being clinically meaningful. And the third was the advent of SBRT, which is near and dear to me, of course. But the idea of using high doses of radiation focally in limited fractions, which would permit patients to get in and out of radiation very rapidly, because at the end of the day, these patients have systemic disease and they need systemic treatment. So all of those novel ideas developed a confluence over the last few decades and really made it opportunistic for us to use local therapy for a survival benefit. The other important point to note is that most of the time when a patient with advanced non-small cell lung cancer progresses, their first site of progression is in their original sites of gross disease. So the initial early studies look to see if patients with oligoprogressive disease, for instance, could get local therapy and for that disease to be eradicated, so that all that was left for the systemic therapy to do was really focus on improving clearance of microscopic disease. So that's an oligoprogressive condition where a patient has disease, has been on systemic therapy, and they have a few lesions that progress. This study, NRG LU002, took a different tact. Rather than waiting for progression of disease on systemic therapy, we thought that it would make sense to give a patient induction systemic therapy or first-line systemic therapy, get a maximum initial response, and then our idea would be to consolidate all of the what we call oligometastatic disease or all of the remaining residual disease. And the idea behind that was to, one, again, give us an insurance policy that original sites of disease would not progress on systemic therapy. Matter of fact, now we realize that probably the radiation is also helping with avoiding the development of acquired resistance on systemic therapy. But it also gave us an opportunity to try to control the disease. In any event, that's oligometastatic disease in the setting of consolidation. We have oligoprogressive disease, which I just talked about. And patients can have oligometastatic disease from diagnosis through their disease course. And those are truly oligometastatic or oligopersistent patients. You could also have oligo-induced disease, where a patient was diagnosed with, more than 5 or lesions, and by the time that they reached the point of consolidation, they did have 3 or fewer, 5 or fewer lesions that would make them oligo-induced. So that's kind of the gist of the area in the field and how we kind of evolved into considering radiation in these settings.
So I kind of just want to put things in perspective and point out to everyone that this work you've done has been the culmination of almost 15 years of work, dating back to when you and I might have been putting patients on some of these initial oligometastatic trials. And again, really, congratulate you on the culmination of over 10 years of work on this. And so without further ado, can you fill us in on the principal findings of LU002 presented last night at ASCO? I feel very honored to have been able to have attended that in person.
Absolutely, Stephen. So again, just to set the stage, the study was a phase 2, phase 3 randomized study with the goal of identifying patients who, as we talked about, had metastatic disease at diagnosis. It could have been de novo metastatic disease, or they could have been patients that had been treated for earlier stage disease and recurred in a metastatic pattern. So all of those patients were eligible for the study. And then the next thing that we needed to prove in order to promote the eligibility of these patients was that they would all receive at least 4 courses of systemic therapy. And then after the 4 courses of systemic therapy, the patients would be re-imaged, and we would need to establish that they would have 3 or fewer sites of extracranial metastatic disease. And if they had had a stable disease, partial response leading to that scenario, then they would actually be eligible for randomization on the study. And randomization was to a control arm, which was maintenance systemic therapy alone, or to a arm that included local consolidative therapy, which did permit radiation and or surgery, followed by maintenance systemic therapy. Stratification variables included squamous versus non-squamous histologies. Stratification also included the presence of immunotherapy containing regimens. The randomization was done in a 2-to-1 favor in support of the experimental arm. So in terms of high-level findings, what we found was that there was, at 1 and 2 years, no significant difference in progression-free survival. And in part because there was no significant difference in progression-free survival at 1 and 2 years, the study was close to enrollment after the phase 2 portion of the study, and there was no longer any further enrollment to the phase 3 portion because we didn't meet a pre-specified benefit with respect to hazard ratio. All in all, there was no difference in 1 year and 2 year PFS. There was no difference in 1 year and 2 year overall survival. And there was a slightly increased toxicity, both grade 2 and higher, as well as grade 3 and higher pneumonitis associated with the local consolidative therapy. And so, this was kind of the top line findings for the study.
I think a lot of us were hoping for radiation and local consolidative therapy to move the needle forward in a significant way for metastatic non-small cell lung cancer. There was so much promising data going into LU002 from decades of work and some preceding smaller randomized phase 2 trials, including patients with non-small cell lung cancer that should benefit. Why do you think we didn't get the results out of LU002 we were hoping for? What has happened in the last decade that might have changed the game for oligometastatic lung cancer? Is there still hope for subsets of patients to have benefit?
So Lauren, I think that's these days I would say $1 million, but that would date me. I guess it's a $1 billion question these days. But at the end of the day, I think there were several reasons why we did not see a similar benefit with the use of local therapy than we did in the previous studies. Number one, the randomized phase 2 studies, incredibly important, incredibly powerful, that were conducted over the last decade, all preceded the area of immunotherapy. And this was always something that I had some concern about in the back of my mind, is that as systemic therapy gets better, it could, if it's not synergizing with radiation, or is not additive with radiation, could squeeze the benefit that the radiation or local therapy was offering in these advanced settings. And I think that is true if you looked at, as we talked about, if you looked at the 1 year and 2 year PFS and OSs, the control arm did incredibly well. I would say, and all these previous studies did not incorporate immunotherapy. And so we really were extrapolating from immunotherapy alone trials in non-oligometastatic patient populations for the statistics that drove our determination of number of patients needing to be enrolled and assumed endpoints with respect to PFS and OS. So I think those were incredibly significant issues going forward. I would say we were extremely pragmatic in the approach that we took to enroll patients. And the reason we were so pragmatic was because historically, and comes from the NCI, studies that have tried to randomize patients to radiation or no radiation, at least in the lung cancer space, have been incredibly difficult to enroll to. And so we were probably overly pragmatic about who we designated as potential eligible patients. So that means we included patients with synchronous disease, meaning de novo patients with metastatic disease at diagnosis. We included, as we talked about before, patients that developed metachronous disease or metastatic disease after they've been treated for earlier stage disease. We included patients who developed oligo-induced disease, meaning they had more than the number of Mets we would call oligometastatic at diagnosis, and then reached the eligibility after the induction regimen. So those things probably help to add to the heterogeneity of the patient population. We did not have an ideal biomarker that could have said these patients definitely have oligometastatic disease. And it starts to make you wonder how we should define oligometastatic disease. There's an increased effort on my part and the part of my metastatic team at Memorial Sloan Kettering to kind of move away from this definition of oligometastatic based on a numerical value. I think the numerical value is going to be one of many factors, but in some ways we should view these patients as having aggressive or non-aggressive disease. Aggressive defined as people who will likely met out widely on standard of care therapies, and those patients who will not met out widely on standard of care systemic therapies. And that will require us to understand more biology, to incorporate numerical values, but to incorporate imaging and radiomics, biology, and so forth. And that's what we're doing, actually. So in any event, we didn't have a biomarker. And so that also probably contributed to the heterogeneity of the patient population. And so all of these things, I think, added to diluting the potential benefit that local therapy could have offered, and might explain why we didn't see the same exact results as previous studies.
So I think that's so fascinating, talking about oligometastatic disease as really, I think in this trial, the number of sites being 3 is as an arbitrary number. Really, we shouldn't be just using a number, but using more sophisticated metrics to define oligometastatic disease. It reminds me of my conversations with Dr. Bruce Minsky, who's the principal investigator of the esophageal trial, intergroup 0123, and he's told me why is it 5 centimeters above and below the tumor? And I said, oh, because of surgical series, because of I kind of was getting. He's like, no, it's because I've got 5 fingers, and if I was an alien and I had 6 fingers, it would have been 6 centimeters. So,
Right, right.
I think that's absolutely the direction we should be heading. And so, in retrospect, is there anything you might have done differently? I know you've kind of touched on some things, but things you would have done differently in the design of LU002. I'm obviously hoping that some of these insights might inform our next oligometastatic trial at NRG Oncology. And I wonder, should we be applying local therapy up front at initial diagnosis rather than after systemic therapy in the immunotherapy era? The reason I think about this, the original Pacific trial for stage 3 lung cancer, you did your local consolidative therapy, your chemoradiation up front, and you followed it by immunotherapy. That was a hugely successful trial. Similarly, what's also being presented at ASCO this year is the Adriatic trial for limited stage small cell lung cancer, where again, the local therapy with radiation and chemotherapy is given up front and then followed by immunotherapy. So, tell us if you have any insights on how we might do things differently next time.
I would say that a little bit of patience, it's easy for me to say, but a little bit of patience is probably necessary. And the reason I say that is because we are actively pursuing the subset analyses of the trial, and we're looking into all of these questions, whether metacrinous versus synchronous made a difference, whether oligo-induced versus not made a difference, whether the patients that received immunochemo versus immuno monotherapy made a difference. So, we'll be looking at a lot of these factors to try to determine, where we could develop a predictive marker. We also have the blood specimens for CTD analyses that Max Dean, our translational co-chair, is going to perform. And we have it for a large proportion of our patients at diagnosis. At enrollment. So it'll give us hopefully a sense of how to predict for outcomes as well. But I think your point is incredibly well taken. We just chose a point in time to do the treatment, and that point in time was based on in many ways it's based on our breast oncology colleagues who've historically given for a long time neoadjuvant chemotherapy, and the rationale for giving systemic therapy first is it gives a chance for the disease to declare itself. It gives an understanding of how responsive the disease is to systemic therapy. And it also reduces the volume of disease that we may need to consolidate. So those factored into the decision to do it at the timing of consolidation. But I honestly think that you're right. You're hitting the nail on the head in the sense that upfront treatment may be equally or better in terms of long-term tumor control. I think treating at oligoprogression, as we've seen from my colleague Jillian Tsai's work, wonderful work on the CURB study, and she's going to do a phase 3 CURB study throughout the cooperative groups. I think that's going to be extremely exciting, and I think oligoprogression, by the time that patients progress on systemic therapy, they've been on systemic therapy for a really long time, or a much longer time than at consolidation, and so you do have a sense of the natural history of the disease trajectory of those patients, which may be why the oligoprogression is at the right time. If you remember, Stephen, we worked on a study with the University of Colorado back in the 2010s, early 2010s, that was published in JCO in 2014, where we did have 24 patients that were treated for oligoprogression, a single-arm phase 2 study with SBRT, and that was probably the earliest prospective study that looked at that patient population. We probably should have pursued it much further and much more rapidly afterwards. But in any event, I think sequencing is incredibly critical for optimizing local and systemic therapies, especially in the era of immunotherapy. And so there's still a lot of homework that we need to do. And that's why I say patience is important, because I certainly feel that we need to get a better sense of the biology of the disease trajectories of these patients, or the clinical trajectories. And only when you get a sense of the clinical trajectories will we be able to ascertain what the right timing is. And I really meant it when I said it yesterday during the Q&A session that the goal is to determine when we should use local therapy. That when could be if a patient has 12 Mets, but it could be because we know that if we eradicate the disease in those 12 Mets, the likelihood of acquired mutations is limited. The microscopic disease won't show up for 2 years on standard of care systemic therapy. If we had that kind of predictive capacity, that would be the right mode of action versus a patient that has one Met. Okay, but it's one cross-sectional imaging evaluation in time. And then, but what we realized is based on their patient's biology, their host tissue biology, that they're going to met out to 15 new sites in about 3 months. We would never offer local therapy. So I think we're generating that data based on population-based big data analyses and based on the prospective trials we've completed, but it'll take some time.
Now, with all this being said about how we may better apply local therapy is, I think, a nice finding of LU002 is that it doesn't look like local consolidation with radiation had worse side effects than systemic therapy for the most part. You've obviously done a ton of work with prospective quality assurance in LU002 to ensure safe radiation plans. It seems like we've come a long way with ablative radiation. If nothing else, does LU002 essentially show us that local consolidation can be done safely with stringent guidelines and quality assurance?
Yes, Lauren, I think that's absolutely right. I mean, I was part of the team. I did the quality assurance for pretty much every case, along with some colleagues, very valuable colleagues on the team. And you're absolutely right. I think we could say, and this is a model study to say that SBRT can be delivered safely to pretty much any part of the body with good quality control. And what I really viewed in a very extremely positive way was that the study included 68 sites that enrolled at least one patient onto the study. And I will tell you that a large percentage of the sites were not your bread and butter large academic centers. They were actually smaller academic centers, or almost these kind of academic / private practice enterprises. And I spent a lot of time talking to the principal investigators at these sites, and they developed a comfort in being able to assess these patients and manage them with the local therapies. So I think, yes, I think you make a great point that that type of buy-in across the board, across both private and smaller academic and larger academic centers, is going to be something that we could build on for future studies. Absolutely.
And I think I'd also like to put in perspective here, while there was a marginal amount of toxicity associated with local consolidation, I think really in the broad scheme of things, when you think about, let's say, a phase 1 first in humans trial or, high dose leukemia kind of chemotherapy, I sit on the institutional review board at my institution, so I'm very familiar with the toxicity with those approaches and with those kind of clinical trials. I mean, this amount of toxicity really, pales in comparison to some of those clinical trials. And so the last thing I'd like you to do, could you put the findings of LU002 in a broader context? NRG Oncology essentially did a companion trial called NRG BR002 for oligometastatic breast cancer. This was led by Stephen Chimera with essentially identical findings. What might these two NRG trials taken together tell us about the oligometastatic paradigm?
Yeah, I mean, I think, well, I will start off by saying that it's not that we did not use a biomarker for these studies. The biomarker was the number of Mets at a given point in time in the disease evolution of these patients. So we did. It just is, we will end up realizing that because it was, again, a cross-sectional evaluation, and doesn't really take into account what could happen in the future because we don't have those predictive models yet. That was the best biomarker that we could employ. But I think And I've told you this, Stephen, in the past. I have a high respect for our medical oncology colleagues because in many ways their whole approach is driven by science, and very significant biologic efforts to try to understand how and when to apply systemic therapies. As you could see from the studies yesterday looking at lorlatinib, we were all amazed at the incredible PFS benefits that that drug offered. It was because it's such a directed treatment. And I think we will get to that point as radiation oncologists. We will figure out when it is ideal to use local therapy based on a biomarker driven approach. And that biomarker may be a set of 5 factors. It may be a set of 3 factors. It may be, we'll just have to see. We need to be unbiased when we look at the multimodal data. But I think with, as you pointed out, both studies employed a same paradigm, which was a number of lesions at a specific point in time to establish the eligibility, and we need to go well beyond that. And I think this is, and I don't want the field. I fear that the field will rush into now catching up and doing upfront treatment, doing further studies at LCT based on some other parameters without really diving into the biology and the clinical context. But I think there are some of us who will really kind of pursue that approach before moving forward with the studies again. There was a study, just to finish off here, there was a study at MSK, and Lauren must know about the study with the colorectal cancer patients that were MSH high, I think, and they received a specific targeted therapy for their biology of their tumor, and 24 out of 24 patients had a complete response. And though that's an extreme study, that and we wouldn't see that necessarily with radiation because it's tumor intrinsic biology as well as host biology that determine a radiation induced tumor effect. That's the type of result we need to strive for. And remember, that was a 24 patient study. I don't think there's going to be an FDA approval based on the 24 patient study, but remember, ALK inhibitors, Stephen, this, ALK inhibitors were approved based on phase 1 trials. So if you do the studies right, driven by appropriate precision oncology, if you will, we will get the right answers and we will know when to use local therapy for which patient populations.
I couldn't agree more. And that dostarlimab trial in those mismatch repair deficient rectal cancer patients is truly remarkable, and a great goalpost for all of us. It's hard to do better than 100%. I'd like to thank you again for joining us and to congratulate you again as well. For those of you interested in other NRG oncology studies presented at ASCO 2024, stay tuned for additional upcoming episodes.
The NRG Oncology Group is supported by grant funding from the National Cancer Institute of the National Institutes of Health, and the content of this podcast does not necessarily represent the official views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy trials.